So, hi friends, this is Srinivas Samavedam, one of the administrators of the Hyderabad Intensive Care Symposium Group and also an active member of the Learning Platform. So today I thought I will take you through a basic approach to uh, a patient in shock. I may not talk about high funda approaches like biomarkers and what is lactate clearance, but I'll take you through a pathophysiological, clinical, and sonographic approach to a patient in shock. Now, this is an important topic. The reason is it is one of the most frequent indications for admissions into the intensive care unit, in the sense that hypoxia and hypotension are the two most important indications why patients get admitted into the intensive care unit, and restoring the oxygenation of the patient and restoring the hemodynamic homeostasis of the patient are the key roles of an intensivist. Unlike textbook descriptions, unlike what is described in physiology practice, shock that we encounter in the ICU is usually multifactorial. And we need to understand at which point of time what pathophysiological process is more active in the pathogenesis of shock for these patients. Irrespective of how well we treat a patient in shock, most patients in shock have multiple organ involvement. Shock per se is a manifestation of hypoperfusion or manifests with hypoperfusion. So cerebral hypoperfusion, renal hypoperfusion, hepatic hypoperfusion, splanchnic hypoperfusion, and ultimately cardiac hypoperfusion are always coexistent and interlinked when you are dealing with a patient in shock. Therefore, a quick response is crucial, for which a proper understanding about what you are actually treating the patient for should be is very essential, and that's the purpose of why I'm coming to you with this presentation on approach to shock. And unlike what textbooks of critical care describe in a compartmentalized way, that there is one particular type of shock with X amount of features and Y amount of radiological hallmarks, overlaps are very common. Simple example is being somebody with a cardiogenic shock after acute myocardial infarction, recovering in the intensive care unit, developing a bloodstream infection, and therefore developing septic shock. Similarly, a patient who comes to your ICU with a septic shock, for example, intra-abdominal sepsis, for example, recovering from septic shock, develops a PTE and therefore develops obstructive shock. So overlaps are common, and multiple etiologies or multiple pathophysiological mechanisms can be happening in the same patient at same point of time. So we'll try to define shock. We'll look at the types of shock, probably also look at the etiology of shock and a diagnostic and a very basic therapeutic approach. I'm not going to talk about mechanical support, which I will deal with in the subsequent talk, but we will talk about the basic therapeutic strategy for all these patients who present to you in shock. If you ask me what is a normal cardiac output, I cannot put a figure and say this is normal cardiac output. So by definition, shock is an imbalance in tissue oxygenation, tissue oxygen demand, and the tissue oxygen supply. What you want and what you're able to get, and the imbalance thereof is what determines or what defines shock. And the state in which it is, if you want to extend this definition, it is the state in which profound and widespread reduction of effective tissue perfusion leads first to reversible and then, if prolonged, to irreversible cellular injury. So, as intensivists, our job is to actually intervene and pick up the manifestations of shock when it is still in a reversible state. There is no point in us trying to clutch at the last straws when the shock has reached the irreversible vasopressor refractory stage. So there is nothing called as a cardiac output. For example, if I'm sitting here and talking to you with a heart rate of 65 or 70, for me, a cardiac output of about 4.5 liters is probably too good. But if I'm standing on my treadmill in the morning and running at 7 k's an hour, a cardiac output of 4 liters is low cardiac output. So it is always cardiac output has to be described or discussed in the context of the physiological demand of the patient. So if you look at the pathophysiology of shock, it is characterized by impaired tissue hypoperfusion. And because there is impaired tissue hypoperfusion, there is tissue hypoxemia. Now, this tissue hypoxemia will lead to a circulatory redistribution and triggering anaerobic metabolism. The circulatory redistribution produces ischemia and sometimes, if you are good enough, produces reperfusion injury. And the anaerobic metabolism triggers a lactic acidosis. The ischemia and the acidosis will cause cellular dysfunction, which results in triggering a systemic inflammatory response, which perpetrates a multiple organ dysfunction syndrome. This, in a nutshell, is the pathophysiology of shock. So we have learned in textbooks from MBBS days and post-graduation days that there are 4 classical types of shock. This clinical shock, that means distributive shock, cardiogenic shock, obstructive shock, and hypovolemic shock. Maybe you can also consider endocrine shock as something that is beyond the spectrum or beyond the description of these 4 varieties of shock. So whenever you want to understand shock, we should go back to this classical picture, which everybody knows and everybody talks about, is the tank, the pump, and the pipes. So you have a very good pump, which is actually connected to a very large bore pipe, this is the heart for your pump, and these are your blood vessels. But now this pump and this pipe are of no use if this tank is empty. So that tank is the crux. That is the intravascular volume. That is the most important thing. At rest, there is some intravascular volume that is circulating in the venous side, which is called as the unstressed volume. And you need to bring this back into circulation in periods of stress. And that is something which hemodynamic optimization involves. Now, the heart, while we call it as a pump, there are certain intrinsic differences between a mechanical pump and the heart. The heart, a unique creation by itself, pumps relentlessly as long as you're alive and it is able to get its nourishment, but it does not generate negative pressure. It responds to a stretch of its myocardial fibers by volume. So that comes from the venous return. So that little bit of pressure which starts triggering the muscle to contract in the heart and for it to continue pumping is called as the main systemic filling pressure. So this tank actually generates that main systemic filling pressure, followed by a good pump, which is pumping forward, and you get the water that is coming out of these blood vessels into the tissues, that is the cardiac. This what you are seeing in the stream of water can be correlated to your cardiac output. So you can have a problem in the tank, you can have a problem in the pump, or you can have a problem in the pipes. Or if the pump is pumping well, the pipes are good, and the tank is full, you could actually be blocking this pipe, which is an obstruction. So if you look at an empty tank, you can call it as a hypovolemic shock. If you are looking at a weak pump, that is the pump has no enough horsepower, it is a cardiogenic shock. If your pipes are leaking, it is a distributive shock. And if the pipes are pumping well, but the pipes are blocked or the tap is closed, you are looking at an obstructive shock. So this is a simplistic description of the various types of shock, which we all know. However, there may be overlaps. So, for example, a patient with cardiogenic shock may have a tamponade. So he may also have an obstructive shock along with cardiogenic shock. A patient who has a DKA can have an MI. So he can have both hypovolemic as well as cardiogenic shock. A patient in septic shock can actually have a tension pneumothorax. So that patient can have a combination of distributive and obstructive shock. So you need to understand the combinations of this shock pathophysiology to understand which is the significant mechanism which is causing the pathogenesis of shock. So if you are looking at shock as an entity, you can divide them into a volume-related shock and an output-related shock. In volume-related shock, you could also either get a loss of volume or a shift of volume. The loss of volume happens in trauma, where the blood loss is called traumatic shock or hemorrhagic shock. You could get gastrointestinal, both upper and lower gastrointestinal fluid losses, which causes hypovolemic shock. And you could get various types of peripartum blood loss is called hemorrhagic shock. Whereas the volume is not externally lost, but internally the volume is leaking somewhere or shifting from the intravascular to the extravascular compartment, like in septic shock, anaphylactoid shock, or neurogenic shock, you get the volume dependent shock. So two types of shock are volume dependent, that is the distributive shock and the hypovolemic shock. Whereas output related shock could be a result of the weak pump where there is a myocardial pump failure or arrhythmias causing ineffective contraction of the heart, or you could get acute myocardial insufficiency or valvular insufficiency. So this is the compromise of cardiac output called cardiogenic shock. But the heart is pumping well, but you have extra cardiac compromise of the output where either it is the pneumothorax which is compressing, the right heart which is obstructed, or all the chambers are affected by tamponade, you get extra cardiac obstructive shock. In all these situations, what is common is there an imbalance between the oxygen supply and oxygen demand. So the genesis of lactic acidosis, the genesis of high anion gap metabolic acidosis is common. A delayed capillary refill time is common to all kinds of shock. So just because the CRT is prolonged, it doesn't mean that it is only septic shock, although it was brought into focus by the Andromeda shock trial. So if you look at the etiology of shock, again, as I said, we looked at the different mechanisms by which shock is produced. You have a hypovolemic shock, which can be produced by hemorrhage, GI loss, dehydration, or capillary leak. You could get obstruction to the RV like a tension pneumothorax, pericardial effusion, RV infarction, or pulmonary hypertension. You could get a poorly functioning LV like in MI, septic cardiomyopathy, toxic cardiomyopathy, a scorpion envenomation, for example, and valvular regurgitation. And you could get distributive shock like sepsis, massive transfusions, adrenal crisis, or neurogenic shock. This picture summarizes in a nutshell the etiology of various types of shock. The most common type of shock which intensivists manage is distributive shock, because sepsis is a very common and a favored diagnosis for most people who cannot understand what's going wrong with the patient. So in distributive shock, there is a capillary leak. The vessels would dilate because of the vasodilatory state associated with septic shock, causing relative hypovolemia and a reduction in the systemic vascular resistance. And the capillary leak worsens with consequent edema and persistent hypovolemia. These changes lead to a reduction in blood pressure and therefore organ hypoperfusion, the first of which is to suffer is the brain, followed by the kidney, or sometimes the kidney first, followed by the brain. With adequate fluid therapy, if you give to these patients, the heart usually compensates by an increase in the heart rate and contractility, but sometimes it is not enough, which then manifests as septic shock. So distributive shock manifests as increase in heart rate, a decrease in diastolic pressure, and therefore an increase in pulse pressure. Because of the vasodilatory state, the peripheries are all warm. The JVP is not elevated in this type of shock, usually manifested by a lack of edema other than in beriberi. The lungs are usually clear, and because of the hyperdynamic nature of the situation, you get a loud first heart sound. So this is a very basic clinical approach to a patient in distributive shock. And usually the ventricles are hyperdynamic. You can see that this is a hypercontractile LV with no regional wall motion abnormality and no pericardial fluid collection. This is how a hyperdynamic heart looks like on echocardiography. When you look at the opposite end of the spectrum, it is cardiogenic shock caused by poor myocardial contractility. And because of the poor myocardial contractility, there is sympathetic overactivity which leading to vasoconstriction in order to maintain the blood pressure. And because of the poor contractility, the emptying of the right heart into the left heart is impaired, which results in high venous pressure, leading to fluid extravasation and edema. So edema, therefore, is a characteristic feature of patients with cardiogenic shock, and which ultimately results in organ hypoperfusion. So the clinical features of a patient in cardiogenic shock would be a variable heart rate, especially if it is triggered by an arrhythmia, with an increase in the diastolic pressure because there is a vasoconstriction. Therefore, there is a reduction in the pulse pressure, And because of vasoconstriction, the peripheries are cold and the JVP is elevated because of the back pressure on the right side of the heart. As I mentioned, edema is prominent in patients with cardiogenic shock. And the lungs, because of the congestion, will show crepitations on auscultation, and a non-compliant LV will produce the third and sometimes the fourth heart sounds. So you can see the echocardiography in these patients. The LV contractility is poor, and the consequence is a back pressure on the right heart, and you can see a plethoric or a congested IVC. So this is the picture of a patient with cardiogenic shock. When you look at hypovolemic shock, which should be the easiest to treat and where mortality should be zero in good units, again, there is a sympathetic overactivity, but it is again, there is because of the low filling pressure, the heart contractility goes down. So this is again compensated by an increase in heart rate, but unlike distributive shock here, the peripheries are cold, the diastolic pressure is increased, therefore the pulse pressure is narrow. But in contrast, in cardiogenic shock also, you get the same combination of cold peripheries and narrow pulse pressure, but here there is no edema and the JVP is not elevated. And here, like in distributive shock, you get a loud start sound and the lungs are clear. So there are some features of hyperdynamic circulation distributive shock and some features of cardiogenic shock in a patient with hypovolemia. And this is what you need to understand. Just because the patient has a high cold peripheries and narrow pulse pressure, if you try to initiate an inotrope, you are actually flogging a dead horse because the tank is actually empty. And here you usually find that the main blood vessel that carries the venous return back into the right heart, the IVC, is collapsed. You can see a nicely collapsing IVC in this situation. Obstructive shock, which intensivists see more often, but not others, and therefore they don't suspect, is a situation where the myocardium is contracting against a high obstruction or a high afterload, which could be in the right side in pulmonary embolism. It could be in tamponade where there is an extrinsic constriction of the contractility of the heart. Therefore, obstructive shock is characterized by an increase in heart rate, a decrease in diastolic pressure, a decrease in pulse pressure, cold peripheries, elevated JVP. And you may not be able to hear the heart sounds clearly in a patient with tamponade, or you may get a loud P2 in patients with pulmonary thromboembolism. So you can see that the RV is dilated and there is a shift of the interventricular septum to the left side in this patient with suspected or proven PTE. So this is the sonographic approach to a patient with undifferentiated hypotension. So you have to look at the hyperdynamic left ventricle, you look at the cardiac views, you look at the IVC, the aorta, you look at the abdomen, and then you come to a reasonable diagnosis of what we are dealing with. I don't want to, most of you would know this, so I don't want to tax your intelligence by dwelling too much on this. So the approach to shock is not always with high funda gadgets and high funda concepts. It is with bedside clinical examination. That is where we miss the bus and we are misled by our inability to pick up the signs of shock. So you need to look at the pulse pressure. If the pulse pressure is less than 25% of the systolic pressure, it suggests a low cardiac output state. Then you can look at the sonography with echocardiography. I'm saying clinical examination with the understanding that blood gas analysis and echocardiography or sonography are extensions of clinical examination of the patient. So you do an echocardiogram, look at the RV size, look at the LV size, the valves, the IVC, and the pericardium. You look at the lungs and look for lung slide, exclude pneumothorax, look for pulmonary edema. Look at the abdominal ultrasound and look at the skin perfusion, that is the capillary refill time. If you want to look at only a physical examination based approach to shock, it is possible. So you need to understand whether you are dealing with a high cardiac output shock or a low cardiac output shock. And for that, you don't need a high funda hemodynamic monitoring tool. What you need is to see whether there is a cardiac output, or whether the cardiac output is increased or decreased. If the cardiac output is increased, you are looking at septic shock or sometimes liver failure. If you are looking at a decreased cardiac output, you look at the veins. Are the veins full or empty? If the patient has a decreased cardiac output with empty veins, you are looking at hypovolemic shock. If you are looking at a decreased cardiac output with full veins, then you look at the breath sounds. If the breath sounds are clear, you are looking at obstructive shock. If the breath sounds show dependent crackles, you are looking at cardiogenic shock. But ultimately, they are not, they don't occur in isolated silos. You can have to look at combos. But if you are not able to fix it and the patient does not improve with your therapy, look at adrenal insufficiency and anaphylaxis, which can also produce shock. And there are certain weirdos like weird electrolytes like calcium, as I said, beriberi, then sedatives, vasoactive drugs. Suppose I put dobutamine on somebody who is hypovolemic, I will actually perpetrate more vasodilatory shock. So we should look at ourselves for this one. So what investigations would you ask for depending on what you suspect is to be the source of the shock? In distributive shock, you may need a lot of investigations, but quite basically, you would need a CBC to look at the leukocyte count and the band forms. You may have to look at the lactate for hyperlactatemia and lactic acidosis, renal perfusion with BUN and creatinine. And of course, you send cultures and you do appropriate imaging if you are suspecting sepsis. For cardiogenic shock, you may look at the ECG to look for arrhythmias and interval abnormalities. You may have to look at the troponin to see myocardial injury. You may have to look at the BNP to look at the amount of stretch the ventricles are facing. Of course, you will do echo, and sometimes you may have to do a CT pulmonary angiogram. For hypovolemic shock, you don't need investigations. You just need to look at the history of the patient. But again, you need the CBC to know what is the extent of hemoglobin. You need to do a blood grouping, an echocardiogram to show whether there's a leaking aorta, and sometimes a CT to show whether there's any leaking blood vessel. In obstructive shock, maybe you will need a CTPA and echo, nothing more than that. Maybe a HRCT sometimes to look at a pneumothorax if your X-ray clinical suspicion is not very clear. And what specific monitoring do you need for patients in shock? For distributive shock, you need to monitor the urine output, which is the most sensitive indicator of cardiac output in a non-CKD patient, the lactate and its clearance, stroke volume variation with all the caveats, and biomarkers like PCT regression and CRP regression. For cardiogenic shock, you need to monitor the ECG, you need to monitor the rhythm. If you have the ability, monitor the cardiac output, you look at the LVOT function, you look at biomarkers like BNP and troponin. Always make sure your magnesium, your potassium are within normal limits in patients who are prone for arrhythmias. For hypovolemic shock, you don't need to monitor, you just need to monitor the urine output and the IVC diameter. Sometimes you may have to use the SVV. This is the type of patients who need least investigations, but have the highest success rate in salvaging these patients. Obstructive shock is, or possibly you probably have to look at the echo and probably you have to measure cardiac output. Sometimes these patients would require a PA catheter. And what focused therapy can you do for the shock based on the etiology? For distributive shock, you actually look at the early aggressive fluid therapy and then go conservative, early appropriate antimicrobial therapy, judicious use of vasopressors, early initiation of RRT with appropriate indications, and of course, sometimes you may have to do blood purification like plasma exchange and CRRT. For cardiogenic shock, you may have to do revascularization in acute coronary syndromes, rhythm control, rate control if rhythm cannot be normalized, inotropes like dobutamine and sometimes levosimendan, mechanical support like IABP and VA ECMO and impeller devices are now available. That is your option. For hypovolemic shock, you have to give fluids. If there is blood loss, control it with surgery and replace the blood. And sometimes you may have to support with RRT to prevent the lethal triad of coagulopathy or trauma shock. In obstructive shock, it is surgical intervention, relieve the obstruction with thrombolysis, catheter thrombectomy, or pericardial drainage. And sometimes you may have to do surgery for these patients. So that, friends, is about, in a nutshell, about shock. This is not a high funda. This is not a high gadget oriented. This is a basic bedside approach, which is applicable to everybody. I hope you enjoyed this. If you have any comments, please do write to me or call me or post the results to me on the WhatsApp group, the Higgs group, and the Pretty Learn groups. I'm happy to answer. Thank you very much.